Good afternoon, everyone. My topic on is outcome analysis of canalicular laceration repair with self-retaining monocanacular silicone stent. I have no financial interest in promoting any implant in this study. So basically, the canalicular lacerations, early studies have said that it's 16 to 26% of all lead tears involve the canalicular lacerations. They are either from the blunt or sharp injury to eye. The age group, which is either from the young children's or 20 to 30 years, which is most commonly affected. If the repair is done inappropriately, it would leads to symptomatic epiphora, and so the best repair should be done to re-establish the normal anatomy of the caniculi, and could be done with the stunting of the injured canaliculus. So there are two ways of repairing, either with direct suture without any stunt or with the stunts. There are two types of stunts are available. One is monocanacular and another is bicanacular. In monocanacular, we put the stunt in only into the injured caniculi, and bicanacular, along with the injured one, the non-injured caniculi is also been put with a stunt, but it makes the uninjured caniculi prone to risk with the operative procedures. So this is the monocanacular stunts. It is a silicone, made of silicone, a hollow tube. One end is open one, and other is a plug-like head, which are all colorate, which help in fixing at the puncta level, which makes it self-retaining. The aim of our study is to evaluate the clinical efficacy of canalicular laceration repair with self-retaining monocanacular silicone stunts. The objectives: we assess the success of this study with either in the anatomical success or the functional success. Anatomical success we assessed with the syringing and probing examination at the time of removal of stunt, that is at 6 months. If there is patency, then we call it surgical success. If it is non-patent, then call it failure. And the functional success assessed on the basis of symptoms of watering epiphora. If there are no absent epiphora, we call it successful. And if it is persistent or intermittent, then we call it failure. Along with it, we also assessing the complications of the repair. And the demographic details of the patients, cause of injury, associated ocular injuries, time duration between injury and operation were also assessed. The study is done in our SMS Medical College, ophthalmology department. We done sample size 36. It was done from December 2016 to 2018. The inclusion criteria: the patient which are coming to us with canalicular laceration, either upper or lower or both. And the exclusion is they have prior surgery to the caniculi or lacrimal duct, or they have dacrocystitis or a fracture involving the nasal bone. It could affect the results. Then pre-op evaluations: the age, sex, demographic profile, the mode of injury, the site of lesion, upper or lower or both, the surgical lag time, the duration between the time of injury to the repair we done, and any associated ocular injuries. Pre-op investigation, blood investigation, viral markers, and NCCT orbit. This is how the repair is done. It is done under microscope. The first we thoroughly cut and clean the site. Here first we put dilate the puncta with punctum dilator. Then we try to find out the medial edge torn end with this punctum. That is the important part. We try to find out the both medial and lateral cut edge of the caniculi. And this is the monocanacular stunts passing through the puncta, and we get it outside from the lateral edge, torn end. And now, after stretching it, you can see this colorate is there, making self-retaining, and the other edge passed through the medial cut edge, torn edge of the caniculi. After that, we suture the lid laceration with the absorbable 70 vicryl suture. This is another case with the cycle hand injury. We can see the first injury with the injured caniculi. Other one we can see we have passed the punctum dilator after the repair. This is the RTA injury, post RTA canalicular laceration. Here the monocanacular stunt can be seen. And after this, the all colorate here, self-retaining one. The post-operative, we given topical oral antibiotics with lubricant drops, and asked patient to advise the patient not to rub their eyes. And post-operative assessment was done at first week, 1 month, 3 months, 6 months, and time of removal of stent has been at 6 months. At every visit, we had done the assess epiphora and fluorescent dye discipline test has been done, and screening and probing examination was done at 6 months after the removal of the stent. The results demographic provides is the majority are male, and is the right eye and the lower caniculi which is involved more. The age distribution, it is the 20 to 40 years of age group which is affected most, and followed by the under 10 years of age infant. They have blouse hook injury. Above that age, they have fall from the cycle, tricycle. The mode of injury in our study we have found is the road traffic accident which have been resulted, followed by wooden stick injury. Infants, there is blouse hook injury and dog bite, other fist and iron wire and stone. They have also been the reason. Then in our study we had operated on the second or third day. So the mean time is around 2.83 days. But we had operated from the 1 day to up to the 12 days. The associated ocular injuries are subconjunctival hemorrhage and lead abrasions. The success we assessed in the form of syringing and probing. In syringing, the results are 35 patients have shown patency and only one failure which is non-patent. Functional success, it is based on epiphora. 34 patients have no epiphora at the time, 6 months, and only 2 patients have intermittent epiphora on and off. The earlier study has also been given the same. The age distribution is young one. The cause of injury mostly road traffic accidents. Gender distribution is male. The other study is also saying the same. Up to 3/4 cases are on the male. The associated ocular injury is subconjunctival hemorrhage. The recommended period between is 3 months to 1 year. We have to put the stents. The studies done on animal model has shown at least it should be 3 weeks, and for in our study we had put it at 6 months. So better healing process and epithelialization of lumen of the lacrimal caniculi. The complication we have faced is 2 cases with early spontaneous removal. That's because of the rubbing of the eyelids. Other complications like punctal cerebral granuloma, which have been there in other studies, but we have not faced such complications. So in our study, this is the anatomy of functional success as compared to the other studies we have.
I think you have passed the time, exceeded time.
This,
Just give a conclusion.
this is the conclusion is we found the self-retaining monocanonical stent is simple, minimally invasive, effective tool for reconstruction of traumatic monocanonical lacerations, and it gives the best high anatomical and functional success in our study with minimum complications.
Thank you.
It was a good study, and I just would like to know from you that what is the opportune time to remove this stent, or you would not like to remove them at all?
At least 6 months.
6 months? After 6 months, how long you would like to keep it if necessary? Or 6 months is the right time, not earlier, not later?
We planned in our surgery
Okay.
study with 6 months.
Next, Pradip.
Next, I will request